If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast.
So I have an interesting topic with this. All right. I don't hate imaging by any means. MRI, X-ray, CT scan, like those things are important and they've been revolutionary for healthcare. I do believe that they are overly prescribed and overly performed. The reason is for the people that I see, right? And here's the reason. Here's what my rationale is on this. Okay, so there's from what I've heard, my opinion, and people that we see with musculoskeletal issues, some kind of pain, that they're coming in like, I have back pain, I have shoulder pain, I have neck pain, knee pain, ankle pain, like whatever, right? Pain in my shin. Questions arise in their head, like WTF, like why am I having this pain? I didn't do anything, right? But they're like, and as an example, there was no mechanism. I didn't get in a car accident. I didn't fall downstairs. This was non-traumatic pain that has now developed in my body somewhere, right? People usually ask, what the heck is going on? And why do I have this? And why is it not going away if it's been a couple weeks already, right? So questions arise and get nervous, as in like, oh my gosh, is something wrong with me? I'm battling this pain, right? So what do? Usually people go to their primary care doctor first, which makes sense. And then the primary care, just to make, hey, doc, want to make sure everything's okay. What do I do, right? Doc would say, hey, this is out of my scope because it seems like an orthopedic issue. I'm going to refer you to an orthopedic specialist. So then you get a scheduled orthopedic specialist and you go to see them. And the first thing they're going to do, I'm very confident, is do an X-ray to rule out fracture and underlying sinister pathology, like a bone mass, like a tumor, right? Like a tumor, all right? So once that's been taken, the next step is to do an MRI. And an MRI or a CT scan, it's to look at the soft tissue structures that are around the joint in the area that's painful. And it's to view and also check out what's going on, not just from the bones standpoint, but maybe more detailed view of the surrounding soft tissue structures. Soft tissue being like the connective tissue, ligaments, tendons, muscle tissue, and labrums as an example, stuff like that. Okay. So the question is like, do I need an MRI? When should I go get one? Like, what's the indicating factors that I should get one? And here's my opinion, because I've had my own pains and stuff like that. Like I'm a two-sport previous athlete in college. I got 3 kids and I exercise and I'm a very physical job, right? I like work with people, do a lot of manual therapy. I show exercises. So things come and go. And that's what I've learned with that is like things come and pain just comes and goes. And it's just in pain right now, right? Things don't have to last forever and doesn't usually mean it's going to last forever or that something is like severely wrong, right? But so I'm a little bit more familiar with just like things getting nicked up, right? And banged up, like tight muscles and joint pain, whatever. On the extreme end of that would be like, imagine like an MMA athlete, right? Or jiu-jitsu or something like that. Those guys and girls are getting their joints torqued and tugged on and twisted the wrong way all the time. Dislocated shoulders, subluxed shoulders, clavicle, their necks get choked all the time, hip and ankles get bent the wrong way all the time. So they're always taking their joints to the extreme opposite end range. And so they're kind of used to it. You know what I mean? So like imagine if someone on the street had never done MMA and never played sports and they put their ankle in a position that felt the same symptoms that this MMA athlete had, they'd be freaking out. But an MMA athlete, it's a familiarity. They're already familiar with that type of symptom and that feeling. So that familiarity and exposure therapy makes it a lot less egregious and less freaking out, right? So anyway, when do I get an MRI? All right, so here's my criteria of like, here's the reason to get an MRI, okay? Number 1, it's to rule out bad things that we think we're missing. As in like, something has been going on and painful, and I don't know what I did, and it's not going away, okay? I've tried conservative therapy stuff like physical therapy and other modalities and stuff, just try to alter my postures at work and with other activities. I've modified my activity and it seems like it's still not going away. All right. So it's to rule out bad underlying sinister pathologies that we think we're missing that aren't just like you sprained your knee, right? Or like an orthopedic musculoskeletal, neuromusculoskeletal type related pain. So it's to rule out underlying sinister pathologies, red flags. We would call those red flags. It's to justify surgery. So I usually ask people like, do you want to get surgery? Do you want to pursue that? And you'd be like, I don't want surgery. I don't want to do that. Even if it's like a moderately severe problem from a musculoskeletal standpoint, people that we see are still like, that seems aggressive. I don't think I'm ready for that. And I would agree. I'm biased, of course, where we've been able to help a lot of people avoid surgery. I don't hate surgery. It doesn't have to be necessary, but it's a necessary thing sometimes, but it's not always indicated, and people can definitely get better without it, even with some severe musculoskeletal derangement and issues going on. Okay. But I don't hate surgery. Surgery's also a revolutionary thing. It's kind of like super advanced. It's amazing. It's just not always necessary. And then the third reason simply is just people want closure. They want to know what's going on. I want to see it. I want to see what's going on. I want to look at it and I want to see it, right? It's just closure is what they're looking for like a clear diagnosis that they can visually look at. But we can be pretty confident that we are most likely what's probably going to be found, right? And there is a cost of psychological and mental health that comes with looking at and consulting with what an MRI might find, right? As in, like, if somebody has moderate back pain, mild to moderate back pain, it's been going on and lingering and it's annoying, with occasional tightness down their glute, we would probably think that it's referred nerve pain down their glute, all right? That's a very common thing. And neural sensitivity, right? And most likely on the MRI for a lumbar spine, there's probably going to be some kind of abnormalities of bulging or herniated discs, narrowing of the disc space, where the thinning of the disc and they would call it like more close to bone on bone, where bone on bone is also a very common term that I hear a lot, but like it doesn't really paint the picture. And it also doesn't represent or indicate a lack of functionality and a prognosis of doom for the rest of your life. There's plenty of people that have bone on bone and they didn't even know it. Stenotic type changes, where narrowing of the foraminal space and osteophytes or bone spurs developed in there that going to compress the nerve available freedom of movement in space. Ligaments that surround the area that are inflamed and hypertrophied, like growing, like they're big because they're swollen and inflamed. And that can also limit mobility in the vertebral joints and the spinal column, and then also in the foraminal space where the nerve root exits. So all those are like very scary sounding things, right? And that's a very common thing, where like over 70% of people by the age of 45 or 43 have some kind of abnormality found in the spine. It's actually more uncommon to not have something going on. So it doesn't always represent functionality, prognosis, or severity of symptoms. There's a disconnect between what the imaging is finding and then a person's actual symptoms, their functionality and prognosis of whether they're going to get better, right? Because plenty of people have good looking imaging, but it's like, it's not really anything remarkable. I don't really know what's going on, but they're in severe pain and they have referred pain and it's very bad. And then there's people that have not great looking imaging. They have a lot of abnormalities, multiple herniated discs, lots of stenotic changes, bone spurs, ligamentous hypertrophy, narrowing of the disc space. The disc fluidity and hydration looks poor on multiple levels, but they feel fine. They're like, I mean, I'm good. I'm like a little tight occasionally, but like I'm good, right? So there's a disconnect between what the symptoms or people are feeling and the actual image that's showing. So I'm not going to hang my hat on just what this image is showing, right? An example, the way to paint that picture again would be like, if there's a skilled radiologist, which are extremely knowledgeable, right? They deserve a lot of respect. That's all docs, right? And they're looking at image A and image B. Don't know who it is and don't know anything about them. They wouldn't be able to tell you who's in pain and who's not. As in like, well, this one looks a lot more effed up on the image and this one looks a lot better. So most likely this guy or girl that has the more effed up image is probably going to be more pain. It's not true. That you can't tell that. Like there's a huge disconnect between abnormality of imaging and then people's pain. It's just very interesting, Right? Like I said, I love it. MRIs are very revolutionary for healthcare. But just going back to but that doesn't always indicate symptoms and prognosis. And I wouldn't jump the gun on personally for myself, my wife, and my kids and stuff like that of oh, we need to get an MRI ASAP, unless we're thinking and surmising that there's something underlying sinister that we're missing. Like imagine if someone was in a car accident, it was pretty severe, and now they're having a lot of back pain. That's a great indication to get imaging. Like you need x-rays and most likely an MRI to rule out serious fracture or other soft tissue damage that might require surgery, right? But litmus test for me that I usually suggest to my patients where I'm based on my professional experience and my opinion, based on how you're showing and presenting, the rationale to get an MRI is to rule out underlying red flags and sinister diagnoses and look at the soft tissue that's surrounding the area. Okay, that's one. Number two is to justify surgery. I don't think you're a surgical candidate right now based on what you're presenting. You're able to move your arm overhead. It just pinches at the top. I don't think rotator cuff surgery right now would bring develop more functional ability than what you have right now. We just got to get it less painful, right? And maybe improve the scapular upward rotation and stability and all the surrounding musculature to stabilize it. Number two is the first thing I said was the ruling out red flags. If we can screen out a couple questions, then we could be 98% confident that it's not an underlying diagnosis that would require medical attention immediately, like a tumor as an example, or autonomic issue or systemic problem, right? Questions like that would be, is it unrelenting pain where you say your arm hurts when you do exercise, right? When you do physical exercise. That sounds scary if it's the left shoulder as an example, because that's a referred pain for cardiovascular events like heart attack type of mechanisms. So it's how do you know it's not a heart attack? Well, is it in your chest or in your shoulder? Okay, it's in my shoulder. Okay, just check one for a little bit better, leaning towards shoulder issue versus a cardiovascular problem, but we're not sure yet. Number two, what kind of exercise bothers it? Oh, when I do shoulder press or heavy shoulder raises. I'm oh, so not running, right? Cardiovascular exercise doesn't bring about left shoulder pain. No, I haven't ran in a while. Okay, so running isn't the thing that causes pain. It's actual shoulder press and shoulder movements that are provoking your shoulder pain. Correct. Okay, check one again for leaning more towards it's a musculoskeletal problem of the shoulder, not a cardiovascular problem in the heart. Does that make sense? Okay, next question. If you don't do shoulder press for a little bit, does it feel better? Yes. Okay, so there's a mechanism of pain that's causing this issue, right? There's a mechanism of injury that's causing more pain. And if we remove that mechanism, things feel better. It's not provoked when you are just walking around or we're just watching TV. It hurts when you actively drive through your shoulder and push up with the weight. Yes, okay. The check one again for probably thinking rotator cuff pathology of some sort or bicep tendonitis. Okay, cool. Good. Next question. Is it unrelenting pain where it doesn't get better at night? It's waking you up. And no matter what position changes, if you sleep on it, it bothers you. Yeah. If you roll over and switch positions, does the pain go away and improve a little bit? Yes. Okay. So positional changes make it feel better, even at night. Yep. Okay, good. Check one again that we're thinking it's more musculoskeletal, right? Like a neuromusculoskeletal pain problem versus a cardiovascular problem. Next question. Have you had any unexplained weight loss where it's you really haven't really been trying to diet, you're not exercising a ton, and you're just losing weight, getting more frail and thin, fatigued, and general lethargy, lethargic all the time? No, I've been fine. I haven't lost a lot of weight. I'm trying to lose weight with working out. That's why I'm going to the gym and doing more stuff. Oh, I see. Okay, so you're not having those red flag signs and symptoms. Cool. Then that tells me I'm 98% confident. Oh, last question. Have you ever had any previous history of cardiovascular events? Myocardial infarction, transient ischemic attack in brain, or other cardiovascular things that's been going on? No. Okay, so then we're, again, very confident, 98%, that it's not a heart issue. Do you have any heart issues in your immediate family? So yeah, well, my dad had that all while when he was in his 70s and 80s. Okay, and right now you're in your 40s. Yeah, but you haven't had any in your own previous history. No. Okay, so that right there is an example of the screen of we're 98% confident that it's probably not a cardiovascular related issue causing left shoulder pain, but rather something in the shoulder, like the rotator cuff, biceps tendonitis, I'm not going to say labrum because that's more of a passive structure. It's not the pain generating issue. It's underlying instability of the shoulder, which we wouldn't work on that, right? Like surrounding muscular strength and stability. So that means that's within our scope. So we're going to take action and intervene with appropriate sports physio, musculoskeletal interventions, and to make things feel better, right? To get better. And that's when we go to objective screening, and we'll watch them and their shoulder move and see if we can reproduce and provoke the symptoms and get a better, clear diagnosis of why this shoulder pain began in the first place. And that's when we start intervening with the right stuff. Hopefully that makes sense. As in, like, we're not just going to do a protocol of shoulder exercises because everyone's unique and things come about. They don't hurt for no reason. Things come about for different reasons for different people. And we have to be very clear and purposeful in diagnosing what was the cause of the cause, right? The cause of your shoulder pain is your rotator cuff or supraspinatus tendon that's lit up, infraspinatus, biceps tendon. The labrum is involved. But see, like I said, it's labrum represents underlying instability of the shoulder, which still is going to be a scapular problem, and then internal stability of the shoulder, which is we're going to crush stability stuff in a non-painful way. Crush was an aggressive word. Just in a non-painful way, we're going to really work on shoulder stability stuff. So that being said, like we're gonna really work on improving the cause of the cause, and the cause of the pain is your rotator cuff structures, biceps tendon, anterior capsule, superior capsule. That's the cause of the pain. But what caused that to get all lit up and involved in the first place? That cause of the cause is what we have to tackle. That's what we have to focus on. Otherwise, it's just going to keep coming back. And that's something we ask our clinicians that we mentor in our fellowship program, in our advanced fellowship, postdoctoral fellowship training program that we do, where we teach this stuff, is we ask them, you've been managing this patient and they're doing better. 3 months down the road, let's say they're like, yo, full go. Like, I haven't seen you in a month. Do your thing, full go. What's the likelihood of the pain not coming back? If it comes back, then that means we didn't solve the actual underlying cause of the cause. And if it doesn't come back, then that means we did a good job, right? We actually had a clear, accurate movement-based diagnosis, and we were able to solve the underlying cause of the cause problem and prevent it from coming back again. I hope that all makes sense. And if you have any questions about MRI and imaging and stuff like that, like I said, I don't hate MRI. CT scan, it's to look at the underlying soft tissue and rule out bad things and underlying sinister diagnoses and justify surgery, and the last thing to bring closure. Those are the three real reasons to get an MRI. It might not always be necessary, and we can always ride the train of conservative treatment and therapy first, and if things get better, like I ask my patients, like, what if we work on stuff for a month and things get better? Then what? We continue to ride that train of momentum, right? And we know that we're accurate. Perfect. High five, right? And that people would still say, like, and it's understandable. I'm not making fun of anybody. It would just be like, I would still want an MRI to look at it. Like, okay, so what you're looking for is closure. Which is like a very expensive closure statement is what you're looking for. And that's understandable. You want to see it. I don't think you're going to get the answers you want, and it's not going to change anything we're going to do. That's a big statement. As in, like, that's a very clear, big point that I wanted to make. It's like, even if we get an MRI, it's not going to change anything that we do, because your scapula still isn't moving. Your shoulder blade is still not moving upwards and rotating enough anyway. You're still slamming into anterior translation of a lack of shoulder's internal stability. We still have to work on that, right? The lat's still dominant and pec minor is still all guarded. All that stuff's messing up and effing up your mechanics in your shoulder and contributing over time, like the straw that broke the camel's back, leading to shoulder pain. And an MRI isn't going to fix that. And it's also not going to change what we do. Anyway, those are my thoughts on that. I'm always open to questions and discussion. And if you have any questions in there, don't hesitate to reach out.